Hello and namaste to everyone. This is Singh from Department of Physiotherapy and from Jyoti Vidyapeeth Women's University. Today we'll be talking about the chemical pathology of acid-base disturbances. So in last lectures, we have already talked about the terms acidosis and alkalosis. So the normal plasma pH is your 7.4 or within the range of 7.38 to 7.38 to 7.42. So now we'll be talking about the terms acidosis. Acidosis is basically decrease in pH between, below 7.38, which is your minimum range, and increase above 7.42 is your alkalosis condition. So in these acid-based disturbances, we also came across the term compensatory response. So and the second thing was your mixed responses. Now these compensatory response can be uncompensated, partially compensated, or they can be fully compensated. And for the mixed responses, they have no further classifications. So for cases of chemical pathology of acid-base disturbances, we'll be coming across the term metabolic acidosis. So it is due to the primary deficit in bicarbonate, and this may result from an accumulation of acid or depletion of bicarbonate, and reverse is true in case of the respiratory acidosis. So when there is excess acid production, the bicarbonate is used up for buffering, and depending on the cause, the anion gap is altered. So what is basically here the term anion gap? So anion gap, the word itself says that there is some gap between the anions. So the sum of cations and anions in your extracellular fluid is always equal so as to maintain the electrical neutrality. So this is obvious that within your extracellular fluid, it has to be neutral. If there is any charge present in your body, it will lead to some of the pathological conditions. So it is important to maintain the neutrality. So the sodium and potassium, they together, they account for 95% of the cations, whereas the chloride and bicarbonate, they account for only 86% of your anions. So only these electrolytes are commonly used, that is your sodium and your potassium. So hence there is always a difference between measured cations and anions. So since as it's always a common sense that there will be neutrality, so there can be no gap. So the unmeasured anion bit, it constitutes of your anion gap. The anions which we are not able to measure is causing the anion gap. So this is due to the presence of protein anions, sulfates, phosphates, and all your organic acids. So the anion gap is calculated as the difference between sodium and potassium, which is mainly present, and HCO3 minus plus Cl minus. So normally this anion gap has a value of 12 millimoles per liter. So this value is very important to know. So you can always be asked what is the normal value for anion gap. So any increase or decrease in this anion gap is showing that your body has some of the free charges there. Yes, some of the free cations or anions, and it has some pathological conditions. So for if we check the anion gap, we can assess the any pathological abnormality. So the next term that we come across is high anion gap metabolic acidosis, which is a HAGMA. So the value between 15 and 20, it is acceptable as reliable index of accumulation of acid anions in metabolic acidosis. Okay. So in case of renal failure, the excretion of hydrogen as well as generation of your bicarbonate it will lead to, these are both deficit. So the anion gap, it increases due to accumulation of other buffer anions. And there is another term that is called diabetic ketosis. So, diabetic ketoacidosis is basically a life-threatening problem. It affects people with diabetes and occurs when body starts breaking down fat at a rate that is much too fast, and the liver processes this fat into a fuel which is called as your ketones, and it causes the blood to become acidic. So, further, the next term we come across is lactic acidosis. So, the normal is lactic acid content in plasma, which is less than 2 millimoles per liter, and it is increased in case of tissue hypoxia, circulatory failure, and intake of biguanides. So, uh, there are different types of lactic acidosis, type A and type B. So in case of type A, there is impaired lactic acid production with hypoxia, and it is seen in case of tissue hypoxia, that is anaerobic metabolism. In case of shock, which can be anaphylactic, septic, and cardiac. In case of lung hypoxia, carbon monoxide poisoning, in case of seizures. And type B, it is impaired lactic acid metabolism without hypoxia. So it is seen in case of liver dysfunctions, toxins, alcohols, inborn errors, mitochondrial disorders, less oxidative phosphorylation, and more anaerobic glycolysis. And in case of thiamine deficiency and a deficit pyruvate dehydrogenase. So, lactic acidosis causes a freezed anion gap, and whereas diarrhea, it causes a normal anion gap acidosis. So, let us suppose that 5 millimoles per lactic acid has entered in blood, and it is buffered by bicarbonate, and it results in 5 millimoles per liter of your sodium lactate and 5 millimoles per liter of your carbonic acid. Now, the carbonic acid is dissociated into water and carbon dioxide, which is removed by your lungs by ventilation, and thus it will result in lowering of bicarbonates by 5 millimoles, and in the presence of 5 millimoles of unmeasured anion lactate with no charges in sodium or chloride. So anion gap is increased, and in contrast, diarrhea, it will result in loss of bicarbonate, and in case of NaCl is reabsorbed more from kidney tubules in order to maintain the extracellular volume and resulting in increase in your serum chloride. So this chloride will compensate for fall in bicarbonate. So the diarrhea will result in hyperchloremic and normal anion gap metabolic acidosis. Now, this gap may be apparently narrowed down when cations are decreased, such as potassium, magnesium, and calcium, or when there is case of hypoalbuminemia. Similarly, in sucrose elevation, seen in case of hypergammaglobulinemia, when positively charged ions are elevated or when cations are increased, or in case of alkalosis when negative charges on albumin are increased. So this was all about a high anion gap metabolic acidosis. So the next term that we come across is your normal anion gap metabolic acidosis. So, but first of all, there are various causes for high anion gap metabolic acidosis. First one is your renal failure, and in this case, there is sulfuric acids, marked sulfuric acid, phosphoric organic anions. There can be decrease in ammonium ion formation. Sodium hydrogen exchange will result in decrease in acid excretion. Next cause is your ketosis, where acetoacetate, beta hydroxybutyrate anions. These are seen in diabetes mellitus or starvation. Now, next will be a lactic acidosis, where lactate anion accumulates when the rate of production it exceeds the rate of consumption. Next term is your salicylate, where there is aspirant poisoning. Next term is your aminoacidurias, where acidic metabolic intermediates are there, and there is accumulation due to block in normal metabolic pathway. Next will be your organic aciduria, where organic acids, methylmalonic acid, propionic acids are excreted. Next is your methanol, formate, glycolate, oxalate, and ions are there. And acids is formed, which lead to increase in Ag, and there is increasing plasma osmolality, and there is osmolar gap seen. So next cause can be your drugs for higher anion gap metabolic acidosis. It can be there can be remarks of corticosteroid, dimercaprol, ethylcrinic acid, furosemide, methanol, nitrates, and salicylate and thiazides. So, as we're done with high anion gap metabolic acid acidosis, we talk about normal anion metabolic acidosis, that is magma, in our next lectures. So, just to go through what we read today is that we came across the pathological acid-base disturbances, where acidosis was classified into metabolic acidosis, which was the first classification we have just read. This metabolic acidosis is also divided into high anion gap metabolic acidosis and normal anion gap metabolic acidosis. And the most important term that we came across was anion gap. And this anion gap is the unmeasured anions which constitute of the anion gap. Okay. And it is normal, the normal constitution is 12 millimoles per liter. And for these high anion gap metabolic acidosis, they have certain causes, of which most important will be your renal failure, your diabetic ketoacidosis, your lactic acidosis. So that will be it for today, and keep reading, keep studying, and I will talk about the further topics in our next lecture. Until then, if you have any issues, you can always contact me, and until then, take care. Bye.